Assalamu alaikum. Good morning, good afternoon, good evening, colleagues and friends. Today we will have another important topic on the series of the webinars that GHD IFNET is used to do over the last 2 years. And today we are going really to tackle a very important, very challenging, and very difficult topic indeed, and which is the good governance to tackle non-communicable diseases in the Eastern Mediterranean region. In fact, multiple determinants shape health and well-being, not limited to health systems and social and environmental factors. Health is also highly influenced by various political, economic, and commercial dimensions and perspectives. Subsequently, addressing these wider determinants required good governance and multidimensional policies to achieve positive change. Globalization, the rapid change in technology, education interconnection, and socio-economical changes led to many demographic shifts and the epidemiological transition of disease. Currently, the non-communicable disease burden is progressively growing, while epidemics and pandemics are still threatening the globe, leading to the increasing politicization of health, yet creating an opportunity to address challenges through strengthened governance. Non-communicable diseases are the world's commonest killer and a major cause of morbidity and disability. Commonly known also as chronic or lifestyle-related disease, they include mainly cardiovascular diseases, cancers, chronic respiratory diseases, diabetes, and others. And globally, 2/3, and more precisely, 71% of deaths are attributable to non-communicable diseases, with low and mid-income countries bearing 77% of the burden of these deaths occurring prematurely. Many of these deaths are preventable through lifestyle-related changes and cost-effective interventions implemented by national governments and others. Due to the nature of non-communicable disease, multi and intersectoral synergized governance approaches are needed, cutting across different levels and sectors to achieve sustainable and equal outcomes for all. The webinar today we are going provides a covering platform of expertise at the global, regional, and country level for knowledge exchange towards discussing non-communicable disease governance and health and well-being. Hopefully, we are going also to address the following: to shed light on the importance of good governance to combat non-communicable disease and highlight the main determinants of current challenges affecting good governance. Secondly, to share best practices through diverse learning from global, regional, and country experiences. Thirdly, to discuss the element of governance and conceptual models to assess governance at the national level. And finally, to propose applicable, sustainable, and innovative strategies to maintain and improve governance. In fact, today we have really a distinguished expert in the area of non-communicable disease as well as in the area of governance, both from the WHO EMR as well as we are going to have the experience of 2 countries in the region, that's Oman and Iraq. Let me first introduce our distinguished speakers from WHO EMR. First of all, we have Dr. Lamia Mahmoud. She's the Regional Advisor Non-Communicable Disease Prevention at the WHO EMR. And Dr. Lamia is a public health professional with a medical background and more than 25 years of experience in the field. She has worked with the public health sector in Sudan for more than 15 years in various positions under the primary healthcare umbrella. Dr. Lamia joined the WHO in 2012 and has worked across 3 country offices. These are Sudan, Pakistan, and Oman, prior to her joining the WHO Regional Office for the EMR in 2021 as the Regional Advisor for Non-Communicable Disease Prevention. Her work experience extends to include various public health domains that include non-communicable disease, maternal and child health, health promotion, nutrition, and health system development. We will also have with us also Dr. Hala Abu Talib, and Dr. Hala is the Regional Advisor for Health System Governance with the WHO Regional Office for the Eastern Mediterranean region in Cairo, Egypt. As a global health professional, she worked earlier in her career with other United Nations affiliated entities at country and international level. She has a profound and lifelong interest in public health issues, including health system governance, accountability, legislation, human rights and equity, as well as evidence-based policies, and planning to apply both a system and a programmatic approach, mainly in the area for reproductive health, health promotion, and injury prevention, and HIV/AIDS in different settings, including fragile contexts. She is a medical doctor by training and holds a medical doctorate in public health from Cairo University and a Master of Epidemiology from the London School of Hygiene and Tropical Medicine. Dr. Lamia, you will start first. You have something like 12 minutes for your presentation, and then Dr. Hala will follow for another 12 minutes presentation. And just one point before starting, we will like to ask our colleagues, the audience, to use the Q&A box at the bottom of your screen to put the question that you like, and hopefully at the end of all the presentations, we are going to address the most important questions. If you have a particular question that you are interested, you can add your thumb. So this is going to have a priority in addressing these questions. Dr. Lamia, the floor is yours, please.
Thank you, Dr. Faris, and thank you to Infinite and colleagues for giving us the opportunity to present in this important webinar. For some reason, again, I'm having a problem with sharing, so it looks like you'll have to share from your side for some reason. It's giving me the presentation from somewhere in the middle. Technology always fails me. So maybe—
Your slides is there, the slides is there.
But it's not moving, unfortunately. Okay, there it goes. Okay, so there it goes. Oh, thank you. And good afternoon, everyone from Cairo, from the regional office. And I'm Lamia Mahmoud. I'll be talking today about the need for governance for addressing the world's biggest disease burden, which is NCDs. And we know the numbers, of course. We're here because we're committed to NCDs, and we know that every second we lose prematurely 28 lives between the ages of 30 and 70, mainly because governments have not taken the required actions to ensure that people receive the preventive and treatment services for NCDs. And out of those 28 lives, 25 are from our low and middle income countries, where the environment and the setup is just not right for these people to receive the needed care and support. Looking at the data, we can see that globally in 2019, NCDs accounted for 74% of all deaths. And the graph on the diagram on the left shows you that 7 out of the top 10 deaths are linked to NCDs. And when we come to the regional level, the data from 2019 shows that NCDs account for 66% of the disease burden, largely driven by cardiovascular diseases and followed by cancers. And countries have made the commitments that need to be made to NCDs. All our member states have already committed to the SDGs. And this busy slide just shows you all those targets under Goal 3, where the NCDs are linked. And countries have committed to achieve those targets related to premature death, related to tobacco control, substance abuse, UHC, and providing the right drugs and technology. But how far have we moved from that? Not very much. And the world will ask us in 2030 how we have contributed to achieving the SDG targets for NCDs. And so far, the global response has showed us that we have actually failed on that. This figure shows you on the left, the 5 risk factors, and on the right, the 5 diseases that we focus on when we talk about NCDs. This is the 5x5 agenda, which you may already be aware of. And the data till date shows us that we are very much off track when it comes to SDG target 3.4, which can only be achieved by addressing what you see on the screen right now. The data to date shows that only 6% of our countries are actually on track to achieve target 3.4. That is only 14 countries when it comes to women and 15 countries when it comes to men. And therefore, WHO does a lot to support the advocacy efforts and communicating with member states to lift the priority according to NCDs in our different countries. This slide shows us the history. It dates back to 2011 with the UN high-level meeting on NCDs. And this was the first meeting, high-level meeting, that put focus on NCDs. You may all know that the UN General Assembly has conducted few meetings few high-level meetings on health issues. One was on UHC, as you may recall, one on AIDS, and we have had 3 till now that are linked to NCDs. There was a cascade of actions that followed this high-level meeting. Of course, before it was the Moscow Declaration by Ministers of Health, then the heads of state for the high-level meeting and different commitments. I won't speak to all of them, but as I've just mentioned, we were lucky to be the focus of these UN high-level meetings on 3 occasions. And the World Health Assembly this year had a record number of declarations that related to NCDs. So this year was indeed a landmark event a landmark year for NCDs. We had focus on the 2030 implementation roadmap for NCDs, a focus on including NCDs in emergencies, target sets for diabetes, oral health strategy being endorsed, great emphasis on strengthening multisectoral action, an action plan on alcohol was endorsed, a focus on epilepsy and neurological diseases, and obesity prevention and management. And this details a bit more on these actions that I have already spoken about. And then again, this year witnessed the International Strategic Dialogue on NCDs that was held in Ghana, in Accra in April. And it was co-hosted by the President of Ghana, the Prime Minister of Norway, and the DG of WHO. And the main focus of this meeting was linked very much to governance. It aimed to raise the priority according to NCDs. It aimed to bring together different partners and stakeholders so that they could exchange knowledge and discuss what would it take for countries, especially low and middle income countries, to achieve the SDG 3.4 target. And also, of course, to raise the priority, the visibility of those countries that are doing well and are leading the work on NCDs. And this meeting also witnessed the Global NCD Compact, which had many commitments listed there, linked to saving lives, linked to addressing NCDs in emergencies, ensuring essential services, monitoring and evaluation, and most importantly, engaging people living with NCDs and moving from these commitments to actions through different mechanisms. And coming up soon is a great opportunity also to raise the priority according to NCDs and strengthen governance is the first annual gathering of heads of states on NCDs, which will happen just 2 weeks from now on the 21st of September in New York. And we have high hopes that we have heads of states from this region will be participating there. This is a meeting that aims to address the high-level governance, the need for commitment, is chaired at the high level by the President of Ghana, and it will ensure that there is regular monitoring to the UN General Assembly. In terms of advocacy work, WHO is aware that the work done by ministry is only the tip of the iceberg when it comes to NCDs and the role of the different sectors. And therefore, this publication that WHO has developed provides clear guidance to the different sectors on how they should be moving forward to address NCDs, what role they can play. And it details the role for each and every entity, what member states can do and heads of governments, what ministries of trade can do, what ministries of finance can do, what ministries of education, and many, many others are included in this. And also, WHO is keen to show that investment in NCDs is really worth it. In December 2021, we published a global investment report that talks about the health and economic benefits of implementing the current 16 NCD best buys. It shows that less than $1 additional per person per year results in 7 million lives saved and $230 billion gained in economic benefits. And the returns of investments by 2030 is that for every $1 invested, we save $7. So it really is worth the effort. Moving on quickly to what WHO technical guidance says on NCDs. At the global level, we're very much led by the Global Action Plan, which was from 2013 to 2020. Now it has been extended to 2030. And this Global Action Plan puts a lot of emphasis also on the needs for governance and how it could be implemented at country level. And then we also have the implementation roadmap that I mentioned earlier, endorsed in this year's World Health Assembly, and it has very strategic directions for countries in terms of accelerating the national response, prioritizing the most impactful interventions, and of course, ensuring data to make countries accountable. Moving from global to regional, we have the regional framework for action for the prevention and control of NCDs that the WHO regional office in the Eastern Mediterranean has developed and updated recently in 2019. And it also has good stress on governance. And moving from that to countries, where we have countries who have developed multi-sectoral action plans based on the guidance delivered by WHO from regional and HQ levels. And this framework, as just mentioned, has 19 strategic interventions, 15 progress indicators, and it addresses 4 areas of work. Governance is indeed one of them. And the governance component focuses very much on planning, national planning for NCDs, including all sectors. It focuses on developing indicators to monitor progress, and of course, having mechanisms, coordination mechanisms in place at country level. You'll hear more of this from the countries when they present their experiences. And we have tools that support countries. We have portals, tell you where you're going and how you're moving and how you're progressing. We have country heat maps that can help identify specific NCD indicators and how they contribute to mortality. We develop guidance for establishing national action plans, multi-sectoral plans. And that toolkit has been used by many countries in developing their plans. And we have a country capacity survey that is done periodically to monitor progress in countries in terms of policies, plans, and different domains. We have not forgotten the people living with NCDs. They are key to the work we do. And the WHO Independent High-Level Commission on NCDs in its report, the second report, actually put a recommendation to strengthen this component. And therefore, WHO is now working on a framework for meaningful engagement of people living with NCDs and mental health conditions. And the picture you see on the right is the EMRO regional consultation that was held earlier this year, because we wanted to support the co-creation and contextualization of this framework so that it's fit for purpose and fits to our region and people living with NCDs in the Eastern Mediterranean region. And now we're moving towards 2025 for that 4th high-level meeting. And this will be an opportunity for countries to reflect on how we've moved since 2018, how we're still having a high toll of deaths from NCDs. It would allow countries to adopt a new and ambitious and achievable political declaration on NCDs and allow us to advance as we move into the next decades. I go back to my question that I put earlier. The world will actually ask us, what have we done to achieve the SDGs? What have we done to achieve the NCD targets for the SDGs? And I've intentionally put the picture of a young child here to remember that what we do today is not only for the people living with NCDs now, but for the generations of tomorrow. We have to keep the commitments we've made and make sure we pave the way for a safe, sustainable future for these young people. Thank you very much.
Thank you very much, Dr. Lamia. Thank you. Thank you for this commitment with time. Thank you. And now the floor is to Dr. Hala. Dr. Hala, are you ready?
Yes, thank you very much. I'm going to share my screen in a second. Okay. Can you see it?
Yes, yes.
Okay, thank you very much. Okay, so good evening, everybody. I would like to join Lamia in thanking Amphinet for this invitation. Thank you all colleagues and organizers. This very important webinar. And the next few minutes, I'll try to go a little more in depth in health system governance functions and how they are related to NCDs. Okay, During my presentation, I'll share with you the conceptual analytical framework that we apply to NCD program. As you know, I'm working with the health systems department, which is which is the sort of like the benchmark or the backbone for all programmatic activities. Our main role as health systems department is to support all programs as well as countries in achieving developing and achieving their policies and plans. So I'm going to share with you the conceptual analytical framework that we applied as a health system department from a governance perspective to NCD program, what the relevant sub-functions, including the relevant sub-functions of governance and the prerequisites, enablers, and giving some country examples, and share some regional reflections and experiences, and end with the summary. So briefly, governance, what is governance? Governance in the health sector refers to a wide range of steering and rule-making related functions, which are carried by governments and decision makers who seek to achieve national policy objectives. Of course, to achieve both universal health coverage and health security. The most important thing is governance. There are different definitions for governance. When it comes to the health sector, we use it as governance is the benchmark or the infrastructure. Imagine you're building a building. You're structuring a building. Governance is the infrastructure that can hold and make sure that the building is kept upright and is functioning and is safe and is actually accommodating the different rooms and the functions like required from this building. So governance, imagine it as the basis or the infrastructure in an architecture, in the architecture of a health sector. It comprises the rule of law. We'll talk about legislations, effective institutions to carry out those policies and plans and develop them and carry them out, which requires a lot of transparency and accountability mechanisms in managing the public affairs of different programs and health systems objectives, taking into account equity and human rights principles and ensuring participation of all citizens and beneficiaries and even the contributors like providers in our case in decisions that affect their lives. Okay, in AMRO, we developed a set of regional strategic directions and prior strategic directions, which to strengthen health system governance, which are all interconnected and interdependent. So what I'm going to share with you is 5 simplified, without going through details of what are the regional strategic priorities that we need to work on in AMRO, and it's actually even global. A lot of countries are following AMRO's steps. So the first one is how to optimize the Ministry of Health role. As you know, that the Ministry of Health is seen in many of our countries as the main and principal responsible entity for health, or public health, as we say. COVID-19 and demonstrated that this is not true. Ministry of Health has a crucial role, but many times it's not, when it comes to multi-sectoral action, it's not as effective. Ministry of Health can play a strong role, which is stewardship, coordination, and development of policies and plans role, and also oversight roles. But it needs to be optimized in a way that it takes into account the other sectors and other actors in the health sector who are acting. This is very relevant also to NCDs, where we work with the ministries, as my colleague Lamia mentioned, while most of the non-communicable disease actions are outside of the Ministry of Health. Also, institutional arrangements. We need to strengthen our institutional arrangements to make sure that the power relations and coordination across actors in multi-sectoral action are optimal. They are working efficiently and effectively in a way that ensures accountability, and that the set multi-sectoral policies and plans are delivered and implemented effectively and efficiently. And of course, this requires a lot of attributes that I'll try to touch upon in the next few minutes. Participatory governance, this is a main crucial element of health system governance to ensure effective policy making. It's related to the health agenda setting, which requires participation of, as I mentioned earlier, of beneficiaries and of the contributors in setting and implementing those policies. So this means the voices of the people and beneficiaries should be taken into account along with the different actors, including public sector as well as private sector, both profit and non-profit. So those actors should be around the table, setting the agenda and then making sure it's the priorities set for different programs are on the table, which varies from one country to another. Finally, regulations and the supportive legal frameworks for health needs to be enforced, because as we know, like in tobacco, for example, a lot of legislations are passed, but unfortunately, they're not being enforced. Same time, when it comes to institutional settings, sometimes we establish a lot of institutions which don't have the authority to delegated authority, which requires legislation, supportive legislations to make sure that they can function and carry out the functions delegated to them. Same with the ministries of health. Legislations are required to make sure that they give the authority to the Ministry of Health or Public Health in some countries to carry out their roles effectively. This is, as I mentioned, those 4 areas are interdependent and interconnected. They are supporting each other, and working on one without the others will not work. So I will not go through repeating the background. When it comes to non-communicable diseases, when we try to work with the non-communicable disease department to see what are the requirements to strengthen governance arrangements for the implementation of the set non-communicable diseases in country level, to fill in the gap of setting the agendas and implementing them. As Dr. Lamia mentioned, there's a lot of gap. We know what needs to do. Countries set their policies and plans, but many times they are not being implemented for many reasons. I would like to attribute some of those to lack of or weak health system governance. Well, in our approach, we focus on essential public health functions, and those are the set of indispensable set of functions and actions that should be the mere responsibility of the government to carry out to protect those functions from market failure. So in doing so, you can see this is the updated set of functions. You can see that governance is one of them. It's actually the core and overarching and cross-cutting, but all functions are interconnected again and interrelated. So this was one of the bases to see what are the governance functions and sub-functions and attributes required when we apply them to non-communicable diseases. And just a reminder, the governance, which I again envision that this is the infrastructure. Imagine a geometrical or an architecture, and the governance being the basis or infrastructure of this architecture. Without it, you cannot build or implement the programs and make sure that they can reach and achieve their requirements and set policies and plans. Governance is composed of complex institutions, different to carry out different roles and responsibilities through different identified processes, which are enabled through government, but require effective collaboration and participation in health decision making with other actors. So it's not only public sector, also private, profit and non-private sector. Governance systematically determines the extent of quality of implementing the essential public health functions. At the same time, the sub-functions of governance in the regional updated list are grouped under 4 broad sub-function areas that are again interconnected but also interdependent. And you're not required here to read through the different boxes. But here I just want you to pay attention to the colored pie. First, the first function, governance functions, which is very much related to NCDs, is how we set setting the agenda related functions, the stewardship functions, and coordination function. NCDs requires multi-sectoral action, which is beyond the Ministry of Health. How can this be coordinated? How can we ensure participation in decision making? How can we make sure that there is oversight of the different actions to ensure accountability and quality in implementation? The second part of the function is sub-function is supporting institutions, infrastructures for implementation. Which I just mentioned, which includes, of course, the multi-sectoral approach for systems building and the implementation of health in all policies, as well as creation of supporting structures and platforms to implement those functions. Sub-functions. The third one is legislations. As I mentioned, most of the NCD related legislations is actually outside the authority of Ministry of Health. When you talk about full nutrition, when you're talking about import-export, when you're talking about tobacco industries, when you're talking about market management and monitoring, and the list is endless. Most of the legislations are outside. And of course, by the legislation, I mean the legislations, core legislations related to managing and implementing the best buys. Most of them are outside the control and authority of Ministry of Health. This needs to be developed. Capacities should be enhanced to be able to develop those legislations and enforce them, as well as we need institutions to be able to really oversee those legislations being implemented and enforced. At the same time, money, financing is very important. All of those sub-functions cannot happen without adequate public health budget, with appropriate criteria for resource allocation, and making sure that those structures have effective health financing to carry and resources to carry out those delegated functions and activities. Quick country examples in Afghanistan. What did they do? For example, there is in Afghanistan there's high political commitment for NCDs, but the problem is that how can this happen outside of the Ministry of Health? So what happened? The Ministry of Public Health in Afghanistan said developed the National Public Health Nutrition Policy and Strategy 2010-13, and to make sure that different actors and sectors and multi-sector action is being implemented. It was implemented under the leadership of the Vice President's office, and there was support of technical secretary to support this happen. To take in account. This served as a coordinating body, enabling previously unconnected partners to function in the structure of acceptable importance, so that they see that all of them are equally important, and they can they see that they are being monitored and coordinated at the highest level of the country. Another example, for example, in Iran, the public health workforce. In Iran, there's this peculiar management where the Ministry of Health and Medical Education is responsible for both the public health service delivery, as well as workforce development. So this allowed also that the ministry responsible for oversight of the country's medical schools, whilst also overseeing healthcare providers and public health functions. After integration of the health and medical education, Iran saw significant progress in workforce availability, capacities, and competencies. This could be a good example where whole of government action can be acquired to coordinate and engage both the education functions as well as the healthcare providers functions. But the problem is that still it requires more effective participation of the civil society and study group and the different actors beyond education and health and public health care delivery. In Oman, and we're going to listen to Oman example, there's another well-developed investment case where the development investing case for enabling financial support for NCDs and in Oman, and this is an excellent example for other EMR countries where they connected between the economists and the healthcare decision makers to make sure there's they can sell the idea of investing in NCDs is worthwhile because it saves money. So the actors who are interested in health as an output talk to the language of economists, who are more interested in the dollar sign or financial perspective. So this helped in selling the idea and advocating for investing in NCDs. And I'm sure we're going to listen more from Oman example. From Sudan, salt iodinization in Sudan started actually at sub-national level. This is a very good example where countries are decentralized, have a decentralized system. So actually in Sudan, it started bottom-up approach. And sub-national laws helped in iodinizing salt at local levels. And gradually, this bottom-up approach helped the government of Sudan and development partners to include actually with support from the WFP to officially extend this to development of a national law supporting salt iodinization, which as a mandatory at a national level. So this is a quick reminder before closing up, is that what we looked at as those four governance sub-functions are very important to work together in harmony and in a supportive approach to make sure that the priority, the NCDs priority set agendas are being implemented efficiently and effectively, applying a multi-sectoral approach. They are interconnected. They are interdependent. I keep repeating this because developing an agenda without ensuring institutional arrangements and taking the multi-sectoral action, delegating clear roles and responsibilities across actors with supportive delegated authorities supported by legislations and financing. If this doesn't happen, we cannot expect the developed agenda to be implemented. So in summary, and this is my last slide, high-level political commitments to NCDs is essential, but it's not sufficient, always sufficient. We need to focus on the highly relevant, more the sub-function area of governance, including for facilitating policy commitment, the global and regional support targets and priorities, as well as advocacy group, including advocacy groups and local champions to make it happen. So don't count that having a commitment and declaration being signed by the country, this is not enough. To translate it, we have to have the governance sub-functions to be working in harmony, consistently in line with the global regional targets and priorities, as well as ensuring advocacy groups and local champions are being identified and integrated in the action taken. We also need to, we're trying at the regional level to also find and identify and build and support countries to have more regional examples which are promising in how those sub-functions are being strengthened and applied, and to have more how to apply and operationalize those actions. Still, we have to acknowledge the major challenges facing governance in EMRO. We had to sustain the high political commitment is this challenge. How to limit the industry influence over regulations, because like in tobacco and diet, they have the money, they have the means, they have the resources to override all our advocacy effects. So that's why we need to learn from their methods and override them and oversee them. Also improve the local data systems to better inform policy, manage and unplanned and uncoordinated growth in private health sector, as well as create an enabling environment for equitable and effective civil society participation. They are the voice of the people, and they can be the ones putting more pressure on the government to make sure that those laws are implemented despite of the industrial influence. Further discussions are still needed to study more the financing and legislation sub-functions of governance and understand how we have to have potentially we can more address the socioeconomic determinants, not forgetting in EMRO that we have countries with emergencies and political unstable contexts where those sub-functions are very difficult to be sustained and established, but still we need not to wait and to start somewhere to make sure that we're building, even during unrest, to make sure that this can be built on as an opportunity in the future. And I'll stop here, looking forward to our discussion. Thank you, Dr. Faris, over to you.
Thank you so much, Dr. Hala, and for this very rich review and a lot of examples that have been mentioned. I'm sure Hopefully, we are going to use them to inspire other countries to use them, considering their context, of course. Now we will hear from the countries, and I will give the floor first of all to Dr. Muna from Iraq. Dr. Muna Atallah, she is the Director of Non-Communicable Disease Prevention and Control Department in Iraq Ministry of Health. And Dr. Muna had been graduated as a medical doctor from University of Baghdad. Then she got the board degree in community medicine, and she was assigned as a director of non-communicable disease section in 2005, and then the section had been promoted to be a department in 2013, and she also the head of that and the director of that department since that time. She's also the head of the Arab Board Council in Iraq Community Medicine Board for 3 rounds, and she's also a member of the Arab Board Community Medicine Examination Committee. Really, Dr. Muna did a lot in the area of non-communicable disease. Among her achievement is the establishment of the essential healthcare package for NCDs at the primary healthcare center, the introduction of non-communicable disease medication and instruments into the essential list of drugs and supplies, and the development of national guidelines for primary healthcare physician on selected non-communicable diseases. She is leading the national multi-sectoral national strategy and action plan for prevention and control of non-communicable disease in Iraq, as well as a prevention of blindness strategy and action plan, and also in the assessment of IDPs. Dr. Muna, you have something like 15 minutes to present, or possible slightly less than 15 minutes if you can, just to get use of the time for the discussion. Now the floor is yours, Dr. Muna, please go ahead.
Thank you, Dr. Faris. Thank you for giving me this opportunity to participate in this important webinar. Thank you, Dr. Hala, Dr. Lamia, for enriching the webinar with the updates. I will talk about the prevention and control of non-communicable disease in Iraq, mainly regarding governance and multi-sectoral action.
Dr. Muna, if you can make it as a slide show, please.
Yeah, sure.
Thank you. Thank you.
Thank you. Yeah, so the epidemiological profile of Iraq, non-communicable diseases represent a main public health problem in Iraq, contributing to more than 50% of total mortality. Every year we have 20,000 premature mortality. The national surveys and reports show that we have 5 million people with hypertension, 2 million people with diabetes, and 12% are at high cardiovascular risk. Regarding cancer, we have 14,000 cases are registered every year. Breast cancer is ranked first, and then bronchus and lung. Mental disorder, we have 18%. Suicidal rate is 1.1 per 100,000 population. Fatality with COVID-19 is due to non-communicable disease represent more than 50%. The national screening system detects 14,000 newly diagnosed hypertensive cases and 8,000 cases of diabetes yearly. We have also, as any other country in the region, high prevalence of risk factors, and the premature mortality rate reaches 3 per 1,000 till the last report. And it also contributes to more than 50% of DALYs. In response to this, and as a commitment to the political declaration, Iraq has developed a multi-sectoral strategy in 2013, and that was updated in 2018, and with a resolution that is endorsed by the cabinet. The monitoring structure is made of several levels. We have the steering committee for prevention and control of non-communicable disease that is chaired by the Minister of Health, with membership of deputy ministers of the relevant ministries and other related bodies not affiliated with the ministry. In addition to subcommittees at each ministry, that is also chaired by the Deputy Minister, the member of the steering committee, in addition to the focal points we work with in developing and monitoring these strategies and action plans, from the tobacco control, focal point, diet and physical activity, finance, legal affairs, and other members according to the need of that ministry. The technical committee at the Directorate of Public Health at the Ministry of Health is responsible for developing the action plan and following and monitoring the implementation with the focal points in the related ministries, in addition to our work on annual basis meetings and monitoring and supervision with the NCD sections at the local levels at the Ministry of Health. The General Secretariat of the Council of Ministers supports the Ministry of Health in monitoring and evaluation of implementation in other sectors. The national strategy adopted the global strategy objectives with some amendments based on local requirements. NCD prevention and control is also introduced into political platforms, national health policy, MH strategy, national public health law draft, and other national public health strategies of nutrition, reproductive health, and school health and health promotion. A budget is allocated by the Ministry of Finance for NCD prevention and control within the annual budget of the MOH and the DOH at local level. Partnership is made to cover the campaigns with the governorate councils and other medical associations. International government and NGOs contributed to selective activities. The main challenges were the economic burden that contributed to limitation of budget, especially at DOH level. DOH means the District of Health at governorate level or province level, with lack of financial contribution to NCDs. Unstable security situation that hindered field implementation, in addition to affecting supervision and contributed to population movement and turnover of the trained staff. COVID-19 pandemic that interrupted also implementation, and until we had to change, put an alternate action plans to restart action again. Lack of coordination between public and private health sectors. Regarding risk factors, mainly we worked on tobacco control, diet and physical activity. Amendment of the National Tobacco Control Act was made to be in line with the FCTC. Sale taxation on tobacco products. Ratified protocol to eliminate illicit trade of tobacco products. Banned e-cigarettes and vape importing or manufacture and distribution. Tobacco-free schools and health institutions is expanding on annual basis. Brief tobacco interventions introduced into 75% PSC through this year. Research on salt and sodium was done in bread and in 24 hours as a baseline for salt reduction policy. Standards for the level of sodium in bread is updated. Policies exist to include vegetable oil in food ration. National legal instructions published on promotion of breast milk. WHO food-based guidelines were translated for. National screening for obesity at school exists. The National Day for Promotion of Physical Activity is set on November 5th. The research on air pollution is done by the Ministry of Environment as a partner. Still, we are still monitoring implementation to accelerate implementation of tobacco control in other sectors. There is still variation in the adherence to sports sessions and activities at school, and limited control on school cabinet and inadequate action against marketing of unhealthy food and non-alcohol beverages for children. So we have to work on that. As for essential care, NCD care screening system was introduced since 2008 actually, and reached 100% by 2012, and then it dropped down and then recovered, and now currently it's covering 80% of the main PSCs. And by the way, we have more than 1,300 main PHCs in Iraq. Cardiovascular assessment reached 40%. Detection diagnosis of chronic respiratory disease was introduced. We added the spirometer and peak flow meter into the PSC centers for the first time. Essential drug for NCD introduced into the list of drugs for PSC apart from insulin and statin that are provided by public clinics. Those are settings after the work hours sharing the same buildings of PSC that provide all the list of chronic disease treatment drugs. 60% of those with high cardiovascular risk receive counseling and drug therapy. Training is continuous on counseling on diet, physical activity, and smoking control. The major NCDs guidelines are updated for PSC physician in addition to translation into Arabic for paramedical staff. An alternate plan for care was developed during COVID-19 pandemic, mainly based on shifting task shifting and mobile follow-up monitoring and self-monitoring instructions distributed to patients, in addition to work on elderly health care homes. Electronic training courses is adopted since the beginning of the pandemic. Regarding cancer, screening and early detection for breast cancer is ongoing. Cancer detection clinics exist at the main hospitals. Mobile clinics for cancer detection are used in several governorates to reach remote areas. Expansion of cancer management centers and units is also we are working on it. As for other programs included in the within the scope of the multisectoral national action plan is mental health, because we have adopted the 5x5.
So if you can conclude in 1 minute, please.
Okay. So this is the mental health, in addition to other programs on eye care, ear care, elderly health care, musculoskeletal disorders, assessment of institutionalized elderly, and assessment of IDP. Regarding, we have the surveillance also has specific, we are able to update the national statistical reports on mortality and screening system. We had the opportunity to have a mid-term evaluation of the national strategy for all the ministries and sectors based on general indicators for all and specific indicators based on their roles. And the results were that nearly 69% were achieved in midterm evaluation, and nearly 50% completed the set target, which was 60%. And by the way, those with low achievement affecting were limited ministries. MOH was able to reach 80% target for the objective 1 and 3 that were low for others. The next steps were acceleration of action plans for selected sectors, sustainable sources for finding resources, and electronic monitoring, extension of time frame to 2025, and updating the strategy based on the global and regional updates. Thank you very much for attention.
Thank you so much, Dr. Amina, for this very comprehensive presentation addressing Iraqi experience. And now we will listen to Dr. Shada Raisi. She is going to introduce the experience of governance of non-communicable disease in Oman. And Dr. Shada is the Director of Non-Communicable Diseases and the Minister of Health of Oman. She is involved in the work related to the prevention, control, and surveillance of NCDs and mental health in Oman. She also supervised the function of the section of disability programs. Among several committees, she's a member of the GCC Committee for the Prevention and Control of NCDs and the rapporteur of the National Committee for the Prevention and Control of NCDs. She is also a member of the National Tobacco Control Committee, the Ministry of Social Development's Technical Committee for People Living with Disabilities, and the Ministry of Health Studies and Research Approval Committee. She is also a board member of Oman Breast Cancer Society, and she was elected as a fellow of the Royal Society for Public Health. Dr. Shada, you have 15 minutes or slightly less than 15 minutes if possible to address. So the floor is yours, please go ahead.
Inshallah, I will try, Dr. Faris. Thank you very much. And thank you to all speakers for those excellent presentations. Certainly the WHO perspective from Dr. Lamia and Dr. Hala, given that the WHO were really influential in producing all of this work. And thank you, Dr. Muna, for that perfect example from Iraq as well. So I will be looking at Oman's response towards addressing the NCD burden through a multi-sectoral action. And first of all, just going very quickly through the burden, NCDs as it is worldwide is quite a significant burden in Oman, leading to 80% of, or causing 80% of deaths in Oman. 21% of these deaths are premature deaths occurring between the ages of 30 to 69. We have quite a significant prevalence of raised blood sugar amongst our population, which had gone up from the 12% figure in 2008. A third of our population have raised blood pressure. And unfortunately, our nationals have significant risk factors. 40% of our population have insufficient physical activity. Our daily salt intake is higher than the recommended salt intake by the WHO of 5 grams. It is 8.5. And one of the alarming things that is happening in Oman at present is there's this growing trend of tobacco use in Oman, which unfortunately at present, Oman is one of the few countries or one of the countries in the region and certainly worldwide who are witnessing these growing trends of tobacco use. Now, the work towards addressing the NCD burden in Oman really started decades and decades ago with the focus on the provision of health services, trying to equip our primary care setups towards integrating and or towards managing non-communicable diseases and the most common illnesses, but also equipping our secondary and tertiary setups. But it could not have been emphasized enough by Dr. Hala and Dr. Lamia, as well as Dr. Muna, that really the work of getting or addressing this NCD burden lies within the other sectors. So Oman began following the 2011 declaration that Dr. Lamia had mentioned, the high-level declaration. Oman established a national multi-sectoral NCD committee with key representatives from all relevant stakeholders, and as well as NGOs and healthcare providers from outside of MOH. And this was established in 2012 and reconstituted in 2015. Also, Oman had developed in 2010 the National Committee for Tobacco Control, which was developed in 2010, as I mentioned, but also reconstituted in 2021 with the change of the government. Many meetings had occurred, many of them discussing progress towards achieving global targets, national targets, but also discussing the implementation of policies and the role of different sectors. And what had happened with the National NCD Committee is that work began towards developing a national multi-sectoral NCD action plan. 8 subgroups were developed, or 8 task forces that focused on different diseases and risk factors. And in 2018, we joined 126 countries from around the world who have national or have set national time-bound targets. And this was this was approved by the ministerial cabinet and launched in a ceremony that was attended by all sectors, as well as many ministers from different sectors. And Dr. Tedros had actually joined that ceremony as well. Now, another effort that was done through a multi-sectoral action was the costing exercise of that national NCD action plan. And this was supported by the WHO. Again, the budget and the proposed budget of this exercise was raised to the ministerial cabinet. Now, that's with regards to the national committees, but we also, as you know, Oman is quite a big country with 11 governorates, and we have 62 wilayats, and each of these wilayats and governorates have health committees. And we have ministerial decrees that really defines what the roles of these health committees are, what the terms of references are, but also who are the key representatives within those health committees. And obviously, these health committees don't just address NCDs, but they do address emerging issues such as what we've seen with COVID-19 and any other emerging issue as well, health-related issue. Now, one thing that we do have as well in the Ministry of Health is the Department of Community-Based Initiatives, who work very closely with these health committees. They help define the roles of the health committees, they help develop the guidelines, they help evaluate different projects to make sure that we are in line with national and global targets as well. So at present, the Department of Community-Based Initiatives, as well as the health committees, are working on 41 projects in Oman. 35, these include 35 villages and 6 cities. And we're happy to have had the city of Sur declared as a healthy city in 2019. And there are other projects that are working towards or progressing towards getting that declaration as well. And we're hoping to have Masaira as the first healthy island in the region. Now, as we all know, things could get very slow, but we try as much as we can to ensure that we maintain that multi-sectoral dialogue and involvement. It is very easy for the other sectors to really go about doing their own priorities. Everyone has their own priority within the sectors. So it becomes very important to make sure that we keep maintaining that multi-sectoral dialogue and involvement. And as mentioned by Dr. Hala, Oman had conducted the Case for Investment in Prevention and Control of Non-Communicable Diseases, which was a project led by the Gulf Health Council. And we had different teams from different international organizations, mainly the United Nations Interagency Task Force, the UNDP, as well as the WHO. Now, what had happened while we were developing or working on the NCD investment case, we were engaging the other sectors. So certainly when the mission and the team, the investment case team were here in Oman, they met with different stakeholders, mainly the Ministry of Commerce, Ministry of Education, the National Center of Statistics and Information, but as well as the Parliament. So we had the team meet with the Shura Council or the Consultation Council in Oman, as well as the States Council. And it was quite a huge project, and we certainly continue to use it to try and advocate for the importance of prevention strategies toward addressing NCDs. Another thing a strategy that we continue to do is certainly in the Department of NCD is we make sure that our stakeholders and other sectors are updated with the information and knowledge. So for example, just an example, 2 weeks ago, we had released the 2019 Cancer Incidence Report in Oman, and this was shared with the Parliament. It was shared with different individuals, key individuals who are working on health-related measures, just to make sure that we continue to keep that dialogue happening. We have other departments within the Ministry of Health who are certainly working with other sectors and engaging very fully. For example, we have the Department of Nutrition, who's working very closely with the private sector on things such as food reformulation and banning certain products, but also and obviously working with the Ministry of Commerce as well. The Department of School Health Education working very closely with the Ministry of Education, as well as Ministry of Higher Education, and community-based initiatives working very closely with the Ministry of Sports Affairs. Now, we felt it was very important not only to have all these interventions happening and having a policy or having this action plan, but also it became very crucial in order for us to monitor the progress. So what started with us trying, we started in 2019 and this was initiated by a mission from by the NCD surveillance unit from the Eastern Mediterranean Regional Office, who came to Oman to help us really build up the surveillance system in Oman. And this had led to work and the development of the National Monitoring Framework of Indicators for the Prevention and Control of NCDs. And this is a living document that is being updated by the stakeholders, led obviously by the Ministry of Health, but trying to make sure that all our indicators are in line with national targets as well as global targets. And it follows a process of ensuring that we have inputs, process, and outcomes, as I mentioned, in line with the global monitoring framework, in line with the sustainable development goals, but also in line with our Oman Vision 2040. And what we aim to do is that it should help us really give that sense of accountability from other sectors, but also that sense of responsibility, so that if by the end of the year, once we start sending out the first report for everybody to see where we are in terms of our inputs, process, and our outcomes, any gaps with inputs or within our process indicators will be identified to whom exactly was responsible for it. The document clearly defines the roles and responsibility, or the roles of different sectors and whose role it is to report these different indicators. But also it defines exactly what the indicator means. It has a definition of the indicator as well as the formula of how to calculate it as well. Now, this is not an exhaustive list, but this is just a few examples of some of the things that have been accomplished as a result of our multi-sectoral action. As I said, it's not an exhaustive list, and I don't think I have really done justice to the many work of the other departments as well in the Ministry of Health. But we've had a taxation. We do have a taxation on tobacco products, sugar sweetened beverages, and energy drinks. We have a ban on e-cigarettes, which we try to continue to enforce. We have a 20% reduction in salt and flour, an all-year physical activity campaign, which is really led by the Ministry of Sports Affairs, but in collaboration with the Ministry of Health. We are continuously discussing with the Ministry of Education in terms of different collaborations and interventions at schools. A discussion is now happening with regards to food reformulation in Oman. We have a ban on tobacco advertising and a ban on partially hydrogenated oil. Now, with regards to opportunities, there are certainly tremendous opportunities that we can see. As I said earlier, it does become rather slow, but at present, we are all sectors in Oman are working towards Oman Vision 2040. And this has certainly caused a big move towards addressing NCDs. Health is a national priority. And the move now, or many of the discussions that are happening with other sectors, is how your policies in that sector would affect my progress towards reaching Oman, my targets in Oman Vision 2040. So that has certainly been an opportunity. The other thing is that we are now working towards decentralization. So, and this was through a statement, and it was announced by His Majesty Sultan Haytham bin Tariq earlier this year. So now governorates have their own budgets. They're responsible to make their own plans. They have full authority to make those plans and to work on the projects. And thankfully, we are now seeing more and more of these announcements. Different announcements by different governorates saying that we are now working on a project that helps ensure that we have that supportive environment for individuals in order to become healthier or to change their lifestyles. So certainly we're seeing different projects that involve, for example, cycling areas, walking pavements, as well as playgrounds, and really changing neighborhoods towards making it more of a healthy environment. This is my very last slide, and the reason I put this up is because it addresses another public health issue, which was a burden here in Oman for decades and decades, and taking the lives of mainly young men between the ages of 25 and 50. But what had happened is in 2009, through a statement by the late His Majesty Sultan Qaboos, who raised his concern with regards to this growing burden that is causing these deaths and causing tremendous disabilities in this society, and that was enough to really create this movement towards this multi-sectoral movement towards addressing policies and implementing policies, monitoring and evaluating it, and really causing this change in the behavior of individuals. And as a result, thankfully, we now can announce that we have 60% reduction in RTAs during the period from 2017 to 2021. So I know NCDs are a different burden because there are many influences, many things that really kind of hinder you because there are a lot of interests, mainly in unhealthy products. But this is certainly an example where through really a governance framework, through a multi-sectoral plan and action, we can achieve and reduce a public health burden. So thank you very much. That brings me to the end of my presentation.
Thank you so much, Dr. Shada, for the great presentation, really, and thank for all the panelists. Now we will have just a few minutes really remaining for the questions and answer. Hopefully we can address many of them in these minutes. And as expected, the first question will be about the impact of COVID on the progress toward the achievement of SDGs, particularly SDG 3.4 regarding the non-communicable disease. And to take this further, really, I mean, there is always, it seems as if there is a competition between communicable and non-communicable disease, which shouldn't be the case indeed. At the end, we are dealing with health, and this competition and shifting of all resources toward the pandemic when it occurred give the impression as if the health people are not really the leaders of health throughout the world. It seems to be run by other people, probably the politicians and so on, because there is some concentration on one area of health, and most of the probably later on we can see, just like what we see with the Ebola, for example, that most of the deaths and the casualties happen really due to not the Ebola itself, but it is the collateral damage resulting from neglection of other aspects of health. So and just a quick glance for Dr. Hala and Dr. Lemia, how do you think these COVID can affect the achievement of SDG 3.4?
Hala, should I start?
Yes, please.
Yes, okay. So thank you for that question. Thank you, Yusuf. And indeed, I think we're all aware of the disruptions to services that happened with COVID due to the higher demand for services, due to even people were unwilling to approach health services for fear of infection. So, and we're aware that also people living with NCDs bore the highest brunt from this disruptions that happened, and that even the susceptibility and the risks with COVID were higher among these groups. WHO did a lot of effort at that time, and they published an assessment that was done in 163 countries. It was published in September 2020 that looked at how services were affected. And it really showed us that even the strongest health systems suffered at the time of COVID across the globe. And therefore, it's the learnings that come out of it. What did we learn? And that's why now WHO has this is repeating this building back better. We have to learn from COVID because it's not the only emergency. We're already seeing other emerging diseases, so we really need to take note of that. And therefore, one of the recommendations that's in the implementation roadmap that I mentioned that has been recently developed is the need to ensure that NCDs are integral and part of emergency preparedness and response. WHO also published a publication on maintaining essential services during COVID. If you're looking for data in terms of what actually happened, you note that the data we referred to is still very much related to 2019. So how far we've moved back, how did we slide? I think it's been tackled in certain publications. The Lancet published an article earlier this year that looked at some of these aspects. But again, I wouldn't have an explicit answer to say how far did we slide back at this point of time. It still needs to be studied. Over to Hal if she has any additional response to this.
Thank you, Lamia. I think the Essential Public Health Functions update that I alluded to was updated applying a COVID-19 lens. That's why most of the actions or governance requirements that we are recommending, and the strategic priorities that are recommended to strengthen health system governance, are based on lessons drawn from COVID-19 response. We've been all talking about during COVID-19 response on whole of government approach, whole society approach, multi-sectoral action, even in COVID-19. So which it's a prerequisite for NCDs response. Lots of the requirements for NCD successful policies implementation requires whole of government approach. And that's why institutional arrangements, strengthening institutional arrangements, strengthening the role of the Ministry of Health stewardship, coordination, and oversight functions, who is required, legislations in place. All those actions can be applied to COVID-19 as well as for NCDs. They are generic. And one of the main findings we discovered when we applied it to different programs, including NCDs, is that the four sub-functions I reflected are relevant to both NCDs, as well as communicable diseases, as well as emergencies preparedness and response. So it's not different agendas. It's the same. There's a call to strengthen the governance arrangements, power relations, role of Ministry of Health, institutions, legislations, accountability mechanisms to make it happen. It's not only, our work doesn't end by having a policy, integrated policy adopted. It's how to make it happen, how to hold the different sectors accountable, make sure that they are overseen, their implementation seen, and the required resources are available. We cannot start planning without having the resources, human and financial resources, enhanced to make it happen. The institutional arrangements should give the authority to deliver those mandates, delegated roles and responsibilities. The ideas is a logical, common sense idea. It's not an invention. It's something we all know, but it wasn't implemented, applied. We're always working in vertical programs without integration. That's why, as Lamia mentioned, integration of NCDs response within the health security agenda, as well as the universal health coverage agenda, is a prerequisite. We cannot have different agendas which are fragmented, and we're adding to the fragmentation because the system cannot apply them. We're taking it as one track, separate. Independence and focus is needed, but integrated has to be taken in account. So again, health system governance and functions are prerequisites to make this happen. This is the lesson learned from COVID-19. Thank you.
Thank you so much. And hopefully this is going to be applied on the ground because we have a lot, a lot of publications and a lot of books. And but at the end, when it comes to reality, everybody will jump from these, away from these guidelines, SOPs, and so on, and they will behave accordingly. And it seems that before that, we think that this is only in our countries, but it seems that all over the world, they are following the same system almost. Even the highly, between two brackets, highly advanced health system in the world, again, they are following almost the same practice. And there was emphasis on the pandemic and leaving all the other emergency issues, for example, and so on. And a study had been done in Iraq, for example. There was a dramatic decrease in the NCD services provided during the COVID-19 pandemic. So again, I think one of the most important area that you all had been shared and on the top probably is the multi-sectoral coordination. And it had been mentioned several times, and I think it is in the heart of the governance because probably here we are in the non-communicable disease, which is, as we all know, it's different from communicable disease. We have a lot of etiological factors, because long latency period, less appreciated by the policymaker, by the professional, by the public, and so on, which all make it not as straightforward the area of a prevention. And from our work with colleagues from the Ministry of Health, we find that without multi-sector coordination, nothing can be achieved indeed, or very, very little indeed. And among those people are the private sector as well as the public. So what are, from your experience, what are the most important, good example really that from EMR countries regarding this collaboration, coordination between the Ministry of Health and other partners, particularly the private sector and the general public, the civil society? I will refer this question to probably to the countryside if they have anything to mention. Dr. Shada, Dr. Mona, if you have anything to, probably you can give the best practices in this regard from your countries. Dr. Shada, you can go ahead, please.
Dr. Faris. So with regards to multi-sectoral coordination, that's the question, Dr. Faris, correct?
Yes, correct.
I think I pretty much explained it in my presentation, but again, we have to say, although the coordination is there, but I think the NCD agenda really deserves us to be bold enough and to make sure that we keep making sure that our voice is heard. One of the things that had happened, obviously, with the, there was a change of government in 2020, and many of the ministries had changed. So now we're waiting for the NCD.
Excuse me, Dr. Cheda, again, sorry to interrupt you. I'm here probably focusing more about the collaboration between Ministry of Health and the private sector, as well as the civil society, rather than other ministries within which again within the cabinet. Yeah.
Again, in terms of civil society, we certainly have many NGOs who are part of our NCD committee, as well as of our NCD or coordination mechanism. I do have to mention, our focus could have been really on other sectors, other governments as well. I mean, other government entities, mainly because they really do have a bigger influence in terms of implementing the policies and the really most important priorities that we do have, certainly within the NCD action plan. But however, while the development of the NCD action plan, and I showed a slide there were different members of the civil society who were included within those task forces to develop the action plan as well. But most likely our emphasis right now is definitely with the other sectors, other government sectors, but the civil society is truly supportive, very supportive of these discussions. We are sitting around the table in many of the discussions, and certainly in the NCD committee.
Yeah, thank you so much. And really, one of the colleagues has asked this question about this public-private coordination, because always this is a challenge. Dr. Mona, go ahead, please. You have raised your hand.
Yes, we still have a problem of this lack of coordination with the private sector, but we are trying to engage them in our meetings, in our activities, and through the syndicate, through the governing bodies, for example, the quality assurance, that is the quality control sectors that cover or monitor their action. But in a limited area. On the other side, regarding the civil society and NGOs, we have to define their roles. I mean, they have to have where to contribute. For example, in celebrating and reaching the community, raising awareness campaigns, participating in the national and global days. They have contributed actually very much. They are very cooperative. So each one has his own role in the action plan. We cannot engage them in every action of the whole national action plan.
Thank you, Dr. Mona, Dr. Shada. Again, I think, please, Dr. Hale, go ahead. You raise your hand.
Actually, this question is touching on one of the main challenges I shared in my slides, is that the engagement of civil society and private sector, which is the profit side, is a challenge. And there's a lot of conflict of interest of the private sector to be engaged in NCDs. Obviously, that's why the industrial, a lot of work, and Lamia can complement, I'll leave it to Lamia to add, a lot of efforts are taken to overcome the resistance and anti-policies actions taken by the industries like in tobacco or even diet, even like Nestle for example, which is a lot of declarations being passed, but the private sector is actually an obstacle, is a bottleneck in making it happen, because they learn how to create demand for their products rather than, and they have the means to do that. So there's a lot of work that WHO has been doing, trying to work with parliamentarians and other actors, legislators and others. But even in parliaments, and I may say, I've been hearing, and we've been hearing different meetings with them, they themselves are under pressure. They are their own re-elections are on the stake if those legislations are passed. That they are politically, even they can politically influence the policies and regulations that are passed. And if they're passed, they cannot be implemented properly. So that's why. On the other side, with the nonprofit organizations, they need to put the government under pressure, or sometimes the governments need the civil society to generate this demand for them to pass their laws and enforce them. That's why the more we help the civil society to organize.
I think we lost the connection with Dr. Hale. So, Dr. Lemia, if you want to add anything, just
setting.
Okay, go ahead.
So I'll stop here, but this is a huge area that we cannot cover in a couple of minutes. Over to you, Lamia.
Just one point I'd like to add is that WHO is always very careful when it comes to private sector, because as Hala mentioned, there's always these competing interests there. And we're cognizant of all those challenges. So WHO is now working on a framework for engagement with non-state actors that is developing to support member states in terms of how do they engage with private sector. And it could be the private, you know, there are many meanings when you talk about private sector. So it addresses all those different perspectives. And hopefully this will come out soon. And we've been even asked to pilot it in some countries of in the countries of our region. But I think always with private sector, it has to be, you always have to think of the win-win, but all be aware of the controversies and the competing interests, as I mentioned earlier. For private sector to give you their information, because we have to acknowledge they play a great role. They are delivering care to a large sector of the population, but they don't not sharing information. So to enable that, there has to be some form of accountability in place. And they also have to see the value of giving this information. So that's something that countries have to work on. Thank you.
Yeah, thank you. Thank you both. I think you already answered my second question about because the private sector can be of two sides, the positive and the negative as well. So thank you so much. You address both of them indeed. There is one issue that I personally would like to ask, because here, as we know, in the majority of non-communicable disease, and we know these risk factors, we need to change the behavior and the attitude of the people. And I think it's quite important, in addition to all what we mentioned about the legislation, financing, and all the component of the governance, etc. But again, mobilization of the people to adopt the change. That's the behavioral change theory and theories of change. The role of the sociologist and should be there in order not only to make it one-sided, to impose on the people to do that, but again, there should be some positive action from the public to adopt and absorb and probably to be a champion in this area. I would like to hear from you about the value of those people in making change in the attitude and the behavior of the people. And correct me, probably you have other idea or other thought regarding this particular point, please. Dr. Lemia, if you would like to comment on that, or unfortunately I see
yes,
that Dr.
Yeah.
Lost, yeah.
So we're talking about specifically civil society, is that it? Or which group?
No, I'm talking here about the changing of behavior of the people, not to be just a passive recipient of what the government and other people impose, but they have to take the initiative to be active in this area. And accordingly, because we are talking here about risk factors in general, and most of these, they are related to the behavior. So we need to engage the how to change the behavior of the people through behavioral change theories and theories of change, and the sociologists probably they will play a role here to identify what exactly can do with the people in order to be obedient, and as if we further become optimistic, they can be even a champion in this regard.
Absolutely, and I think that the way to go is to empower people so that they are able to know know everything and make informed decisions. And also the importance of engaging them. I talked earlier about WHO's work of towards engaging with people living with NCDs, and that's a lot of learning that has come from other similar initiatives. And having people living with NCDs part of the decisions and part of the deciding how things could be changed, I think that makes a lot of difference. Because behavior change is easier said than done. A lot of times people know what's right, but they still go for their wrong behaviors. And changing lifestyle takes a long time. It doesn't happen overnight, and it needs a lot of hammering and a lot of repeating of the messages. And we need to maybe change the way we do things. We've done a lot of negative messaging. We need now to shift to more positive messaging so that people learn the value of adopting the right behaviors. I think these are some of the ways we can tackle that, but it's, as I said, it's not easy, and maybe it would be good to hear from countries how they've also tackled that. I just also want to add that also we've learned from COVID. I think COVID has taught us in so many ways. We need to think of the bright side of what came out of COVID, and I think also the way we're now changing the awareness raising strategies. We're adopting new modalities. We're making good use of technology now, because we know what attracts people, what attracts youth, how we can reach them. And I think these are all good ways of making sure that the right message goes out in the hope that people will change their behaviors.
Thank you. This is a very good example, really, about the COVID. For example, using the mask, we saw that on everywhere that the people are wearing masks, with some exception, of course. But again, I think the majority did that. But when we come to tobacco, for example, shisha, for example, is being now widespread everywhere. So I'm thinking in this way, really. But we would like to hear also from the countries. Dr. Shada, if you have anything to add.
Yes, Dr. Faris, and thank you for the question. I think it is, as Dr. Lamia had mentioned, it's not easy, as we all know, to change the behavior, but we still need the policies to help create it, make it easier to adopt the healthy behavior. One of the things that is happening in the Gulf Health Council, I know, is that the Gulf Health Council is currently using sociologists, using different marketing strategies to really market health. So many of the messages that we are seeing through from the Gulf Health Council, and certainly within that are distributed within the GCC countries as well, that they do develop different strategies. I know different departments within the Ministry of Health as well try to study the attitude and perceptions of the public towards different measures and then address different behaviors. Certainly our breastfeeding campaign took that approach, as well as different nutritional strategies that happened. So I do agree it is not easy, but I think really tailoring it, or really combating it from different measures, ensuring that those policies are in place to help make sure that the behavioral change are an accessible and easy solution to make, but also raising awareness. And one of the things that we're doing in the Ministry of Health is we're currently trying to make sure that the public is as informed as everyone else, as all the other sectors are as well. So we're giving them the information and we're giving them the data. And with the help of social media, we are seeing a pressure that is coming from within the public. The public is now the one who's demanding all these changes, are demanding these healthier environments. So this is something that we're also working towards. But the role of sociologists, as well as understanding the human behavior and why they would why a person would choose different products, that's something certainly is worth studying.
Thank you, Dr. Mona. Sorry.
Thank you, Dr. Shada. You really tackled the whole problem in a good way. we can think of the way that affects, we have to have a target population to work on, youth, school children, because you can invest in those people. And also in social media that reached everyone and mainly affected the young people. The globalization, all the messages, wrong messages that was distributed to those people should be confronted with a similar approach, but with positive messages that, or healthy messages, but in a way that can be, it can be as effective as those messages that were delivered in to those young people. I mean, we have to learn from those people, the way they use and the way they reach. We need marketing, have the ability of marketing for healthy messages. I mean, this is the way you can reach, you can change the attitude, the knowledge, the attitude, and the behavior eventually of us. So we have to invest in youth. We have to have a target people to work on, because they will grow by time and that they can reach their families and their friends. I think this is maybe the first step to work on in an easy way, because you cannot reach all people at the same time. But you have to invest you have to target people and the method you use for communication.
Thank you, Dr. Amina. The last minute is for you, Dr. Hala.
Thank you very much, Dr. Faris. Thank you for raising this very important question. From a governor's perspective, I would like to thank all the interventions made by Lamia, Shada, and Mona. The only thing I think it's very important to make sure that there's transparency in sharing the information between the government and the public. The problem is, and that's what we learned from COVID-19, is that there's lack of trust. The public health messages is not always taken in account or respected or complied with by the people, simply because they don't know why those policies, and they always doubt the reasons why those policies were taken. So that's why participatory governance is very important, and transparency is very important to ensure and ensuring transparency and holding the different sectors accountable is very important. Sharing information is the first step in sharing and changing the knowledge. But when it comes to attitude and practice, the most important thing is also to make sure that you're creating an enabling environment, giving an example, for example, physical activity. We need to make sure that people can exercise, you share the information, you make the environment enabling so that they can practice physical activity, respecting the gender, the culture, the social perspective. So we need to make sure that the demand generated, there's a supply for it. Exactly. So we don't create a supply without generating a demand. So this balance is very, very important, ensuring as well the different arrangement legislations are supporting all those mentioned. Over to you, Dr. Faris.
Thank you so much, Dr. Hale. You raised very, very important and excellent point here. I'm sure it's going to be great use to the audience and to different countries. Again, I think this area of governance, a lot of good example from all over the world. I heard some good example from Mexico, from Argentina, from Philippines, from Denmark, from others. But again, I think we have to look at them very carefully, looking for their relevance, for how much they can do and impact on the ground. Should be cost effective, should be affordable, as well as it should be feasible at the end. So all this should be considered. In addition to that, this again, we have to find some mechanism for monitoring and for enforcement of implementation on the ground. So considering all these, hopefully we can end with some list of good example after contextualization, of course, to the country level. Really, we exceed our time by something like 8 minutes at the end. I would like to thank all the great panelists, really, Dr. Hale, Dr. Lamia, Dr. Shada, Dr. Mona, and thank you, Rabia, and all the colleagues behind the scene who did a lot in having this webinar, and thanks for all the audience, really, for the great question that had already raised, and unfortunately we didn't have the time to address all of them, but hopefully we can have some written responses for the question that we didn't address here. And again, thank you again, and wish you a very good day. Thank you. Bye-bye.